that hierarchy can be very confusing. It can feel like, oh, well, I'm at their mercy. No, 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 no. They are getting the privilege of being at your birth. It is an honor to be in your birth space. And so you should choose wisely. And if that person is not honoring your birth space, fire them and find someone else.
In a world obsessed with convenience and quick fixes, I'm approaching wellness differently. After healing from chronic illness by overhauling my entire life, I'm now on a mission to help women like me to thrive and not just survive. I'm Kristen, and you're listening to the OrganiMama Podcast. So, pregnant ladies, I heard you're making a baby registry. Congrats. Also, why are there 137 kinds of pacifiers? And why does every stroller review argue like a cage match? And what is a wipe warmer, and do you need one? Before you open another tab, hear this. The OrganiBaby Guide breaks down exactly what's safe, toxin-free baby stuff that actually matters and what's just marketing noise. It's going to show you the best items to add to your baby registry, what to avoid, and how to make the whole thing way less overwhelming. So head to the show notes, click the link, and grab OrganiBaby. Podcast listeners can get 20% off with code PODCAST. Hello, everybody, and welcome back to the OrganiMama Podcast. I have a super fun guest here today. I am here with HeHe Stewart, who is a leading childbirth educator, advocate, and maternity care reform expert. With a master's in human development and over a decade of experience, she empowers families with evidence-based birth prep, informed decision-making, and postpartum readiness. She is a fierce advocate for informed consent, reducing unnecessary interventions, and ensuring patient autonomy in birth. Beyond working with families, HeHe is actively involved in legislative efforts to improve women's health policies and expand access to midwifery care. She works to reform maternity care by advocating for patient rights, increased birth options, and improved maternal health outcomes. As the host of the Birth Lounge podcast, she interviews leading experts in pregnancy, women's health, and newborn development, giving parents the knowledge they need to navigate birth and postpartum with confidence. Her work continues to drive meaningful change through education, advocacy, and policy reform. Welcome, HeHe. We're so glad to have you on the podcast today.
Hi, thanks for having me. I'm super stoked to be here.
Yes. Well, today we are going to have a conversation with you about C-sections and VBACs, because this is obviously something that a lot of mothers experience as part of their birth, whether it's planned or unplanned. And so I think it can be helpful, especially from someone who has seen so much birth and knows so much about birth as you, to just unpack this topic a little bit to help mothers understand what all might go into having a C-section, whether it's wanted or unwanted, what they can do to prepare for it, what they can do afterwards, and if that's not something they want to repeat in the future, how they can move in the direction of vaginal birth after a cesarean. So I'm super excited to unpack this topic with you today. One of the first things I would love to ask you is just share a little bit more about your personal hands-on experience with birth.
Yeah, absolutely. So I started attending labors, like you said in the intro, over 10 years ago. And, to be honest, I joke around that I didn't find birth, but birth found me. And I stand behind that. It kind of landed in my lap. I started my career in early childhood education. And through that, it led me to a coworker who shared with me that I would be a good doula. And I didn't really know what a doula was, but I had supported friends before with pregnancies as a friend. And I do have this very maternal energy, and I am this fierce advocate. I'm always protecting people from things that I feel are a little predatory, right? So I'm always the one that's like, just make sure you're thinking about this, or have you considered this? And so it's very much my personality to be a doula. And so when I first entered the birth world, I thought it was literally just going to be like holding hands and rubbing backs and giving some childbirth education. And the deeper I got into it, I really realized just how messed up the system was and how the system is truly not designed to support women in their journey to have autonomous, respectful, hands-off, low intervention births, which is what most people want. Now, there's a subset of people who know going into labor they want an epidural, or they choose an elective C-section. So they choose a chosen scheduled C-section, right? Most women in the US want an unmedicated low intervention birth. However, that same group of the most are going into the hospital system, which is not designed to deliver that experience. It is designed to put you on this conveyor belt of intervention, starting with 39-week induction, and then you get Pitocin, and then that leads to all sorts of other interventions, which is going to increase your risk of epidural, because now you're in so much more pain than what your body would have naturally kind of experienced in labor. And now you have all these other interventions. We've intervened so much that many times it leads to something called iatrogenic trauma. And so now we have a C-section that didn't need to be. It's an avoidable C-section. And then at the end of that very long line of things that didn't have to be, we usually have birth trauma. And so as my career in birth work has kind of transformed over the years, it has been driven more and more and more to, yes, reduce induction and C-section, but by way of actually avoiding birth trauma for women. And I find that if we make our end goal to avoid birth trauma, then usually by reverse engineering that, we can avoid other things like unnecessary interventions, unnecessary inductions, unnecessary C-sections. And then you have actually a whole family at the end, not a family that is kind of broken by the system.
Yes. Preach, girl. That is so good.
Amen.
My listeners know that I am fiery hot on this topic as well, with just passion for empowering women to have the birth experience that they want to. And obviously, like with a husband who's in modern medicine, I recognize that emergencies do happen and things can go wrong in birth. And it's those scenarios where we are super grateful for modern medicine, right? And we are grateful for OBs who are trained in surgery and can do an emergency cesarean and save the life of a baby. But from my perspective, and I'm guessing this is yours too, the C-sections that are happening nationally across the US, that percentage is way higher than it should be.
Yeah, I mean, the World Health Organization estimates that a country of our size and stature and our education level and the resources that we have and the way that our medical system is set up, that we should have a C-section rate between 10 and 15%. Well, currently we've got a 34% and climbing C-section rate. So year after year, it actually goes up. And so, yeah, you're right. You know, a couple of reasons that you would want to have a C-section. If you have something called placenta previa, where your placenta is literally over your cervix, it would be incredibly harmful for you to try and have a vaginal birth. Your placenta is covering the place where your baby needs to exit. And so not only could that cause a demise in your baby, but it could harm you and actually lead to a maternal death. That's a place where we're really grateful for C-section. Another one is a transverse lie baby. So if your baby is not either feet down, butt down, or head down, then that means they're laying across your belly. So their head is on one hip and their feet are on the other hip. They're literally across your belly, horizontally and not vertically. Another place where that baby literally cannot come out of your vagina, right? They're not in the right position. We're very grateful that we have C-section. Those two are obviously not the only examples, but just like quick examples of places where, yes, we're really grateful. But the kicker is that, you know, when we look at countries that have the appropriate amount of C-section rates for their country, they are prioritizing home birth. They are prioritizing midwifery care, and they reserve obstetrical care for the women who actually truly need it. And that's the opposite of what we do in the US. We demonize home birth. We demonize and oppress midwifery, and most people are being seen by an obstetrician, which is not necessarily a bad thing, but they're trained surgeons. And so to think about the medical training that your obstetrician gets, not only does it lean heavily towards surgery, but very little of their actual education is spent on exploring physiological birth. And so they're put down this educational pathway that does teach them how to induce. However, what we find when we look into medical kind of education is everyone is taught about induction a little different. So if you go to hospital A, their induction protocol is one thing. And if you go to hospital B, you're going to get a different induction protocol. And if you go to hospital C, they also are going to have a different induction protocol. And that not only is very confusing to providers, but it gives us as consumers a lot of inconsistency in our results. So it really matters not only the doctor that you choose, but the facility that you choose too, because we know that if you choose a facility that has a 15% C-section rate, you're very unlikely to have a C-section. But then there are hospitals that literally, no lie, you guys, have more than a 50% C-section rate in our country. That means out of 10 women that walk in to have a baby, more than 5 of them are walking out with an abdominal surgery. That is not only harmful, but it's just not natural. We know that that is not nature's way. We know that most babies, if supported properly, will be able to come out vaginally, and we should reserve C-sections, surgical birth, for the ones that really, really need it.
Okay, so I have so many follow-up questions for you, and I'm sure that our listeners are just on the edge of their seats right now to hear more about all of this. So, first of all, for somebody who may have absolutely no clue, can you explain what goes into a cesarean section? What happens to mama and baby during that procedure?
Yeah, absolutely. So it is a major abdominal surgery. So you're going to have a ton of prep and a ton of rehab. We're actually cutting through 7 layers of your body. So you've got obviously your skin, and then you've got your fascia. We're cutting through tendons and muscles. Then we go into your uterus, and then we have your amniotic sac. We've got all these layers. Well, because we're penetrating and cutting all of these layers, all of those incisions, for the most part, there's newer data that shows that we don't necessarily have to close that fascia back. But for the most part, every single layer is now being closed. So you have to think, not only are we putting incisions in multiple layers, but now for months after your C-section, you've got multiple layers of your stomach and your body that need to heal as well. And so this is going to impact you for months on end. You have to think every time you get up and down from the toilet, from the bed, from the couch, from the floor, every time you lift something, the stroller, the car seat, your baby, a laundry basket, every time you sneeze or cough or laugh, anything that causes intra-abdominal pressure in your belly is kind of working against you, because we've got all these layers that are healing. Not only that, but you've got the medical aspect as well. So when we have a C-section, you're at increased risk of certain things. So because we're going into your body, we have an increased risk that there are complications like hemorrhage, or that a part of your body that really shouldn't be nicked or touched is during that process, because it's a surgery. That's a risk that you take on anytime that you have surgery, right? But then you also have the increased risk of infection, not for any particular reason other than, again, that is a risk of surgery. We're opening up your body, and we keep our ORs very clean and sterile, but the risk of infection is always there. And then you have the risk for future births, which I feel personally, a lot of providers, not only do they not take it into consideration when, suggesting a C-section to people, but they very rarely discuss this with patients. And so in future births, you have an increased risk of uterine rupture. It is still incredibly small. And when we talk about VBAC, we'll talk about that, but it's still very, very small and increased risk nonetheless. You also have an increased risk of something called placenta accreta, which is different than what I talked about earlier. So placenta previa, it's covering your cervix. placenta accreta means that it actually adheres to that scar. And accreta doesn't have to have a scar. You can have accreta on any part of your uterus, but it is an increased risk if you have scar tissue there already. That would be something that you want to consider if you are thinking about having or accepting a C-section. And so when we think about this major abdominal surgery, not only is it truly a surgery, and look, you're in an OR, it's bright, it smells sterile, it sounds sterile, you are immobilized because you have an epidural or a spinal. There's a lot of emotions that come with C-sections too that I think a lot of people don't think about and can feel really scary because you do feel very out of control of your body. And it's just a different way to birth your baby. So when you have a vaginal birth, you can look down and see your baby exiting your body. You may even be able to reach down and pick your baby up. With a C-section, unfortunately, it's providers and they get on top of your belly and push your baby down and they pull your baby up. And then if you have a clear drape, they will drop the blue one and you'll be able to see your baby. But there's still several minutes before you're able to actually hold your baby. And that depends on how well you're doing after your surgery, whether you actually get to hold your baby. And then there are some hospital policies that actually stand against skin to skin in the OR. And so you just want to take into account all of that stuff. It's not to say that C-sections are bad. And I don't want anyone walking away saying like, oh, I definitely don't want a C-section because I don't want all those things. Sometimes C-sections are necessary. They are just a different experience. And so if we can avoid it for the people who don't need it, that is best.
Yes. And I also think you touched on this a little bit, but the OB who's performing the C-section, you mentioned that they're pushing down on the belly to get the baby and then they're pulling the baby out. I've heard, I obviously haven't been in the room. Have you been in the room for a C-section before?
Yes.
I've heard it described as being a very violent procedure because of the amount of like shoving it takes on the medical professional's part to like get the baby out of the incision, which is kind of crazy because I don't think I had ever really heard that before.
Yeah, it can appear very violent. And that's why I say, like, they are actually on top of you. And, you know, if you have a situation where, let's say you've been pushing for a couple of hours and your baby is actually already engaged in your pelvis and they're actually kind of stuck almost, you might have it from the other end. They might have to put a hand into your vagina and actually put your baby back into your uterus because they're wedged so far down in your pelvis. We also have something called a fetal head pillow. And we know that that's something that we can insert in your vagina and we inflate it and it'll help get your baby back. So we can have people pushing from the top if your baby is not low enough, or from the bottom if your baby is too low. And so, yeah, it's certainly not a gentle process. Although, if you have the wherewithal to plan for a C-section or you have the time and it's not an emergency, you can do something called a family-centered or a gentle cesarean where you request your arms don't be tied down. You request the lowest dose of anesthesia so that you can still be kind of present. You request that clear drape. You may even request skin to skin in the OR. And just for the record, all the organizations do support it, but we're still waiting for that to kind of translate into hospital policy, which we know is tough.
Yeah. And also, I have heard that it is very rare for this to happen, but there are some OBs that support maternal assisted cesarean. Can you explain what that is?
Totally. So instead of there being a drape between, it kind of lays like across your belly. And as your baby exit, your OB will actually pull up your baby and show them to you, almost like Lion King, if you will, you know, like how they raise Simba up. But in a maternal assisted C-section, they'll drop that drape and you can actually reach down to your belly and pull your baby up. Like you say, it's really rare, but again, these are conversations that you can have prenatally and just be very upfront with your provider and say, look, I want to prepare for a C-section, even though that's not my goal. I'm really hoping to have a vaginal birth. But if I need one, it's incredibly important to me that I get to be involved. And I think that their answer is going to be super telling to you, whether you are with the right provider or not. If they're like, oh, well, we don't do that, that's impossible, and they're not even willing to entertain a conversation with you, maybe consider if this is someone you really want to have your baby with. Like, how much do they actually respect your autonomy, and how much are they going to be flexible with you and helping you get the birth that you want, whether it's vaginal or C-section? Or if they come back and they say, absolutely, we haven't done it much, and I need to talk to some higher ups, but by your next prenatal, I'll have a good answer for you. And I would love to help you have that if that's something that you're interested in. That's a good provider. And they genuinely want you to have the birth that you want to have. And that's the type of providers that we really want to support and give our money to, give our time to, let them have the privilege of being at our birth. And I think that a lot of women forget that hierarchy can be very confusing. It can feel like, oh, well, I'm at their mercy. No, 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 no. They are getting the privilege of being at your birth. It is an honor to be in your birth space. And so you should choose wisely. And if that person is not honoring your birth space, fire them and find someone else, which I know that's very hard in some places in the US. We have a lot of healthcare deserts. There are so many places where you literally only have one hospital within 2 to 3 hours of you. So I do recognize that. But if you can, and if it's available to you, do not continue to give your money and your time and the honor of them being at your birth space if they don't deserve it.
Yeah. And I think another really important part, well, first of all, I just echo everything you said. I think it is so, so important to ask lots of questions before you decide who your provider is going to be, including questions about things that you don't think will happen to you. Like if you're planning for an unmedicated hospital birth, ask questions about how they do C-sections, because that is very telling about what kind of provider they'll be during your desired unmedicated birth. Like, if they're not willing to accommodate what you're asking about C-section, they're not going to be willing to accommodate what you want for an unmedicated birth either. So I think that's very telling. But I think another thing that's really important is that it is never too late to switch providers. Even if you get to 38 weeks and you find out your baby's breech and your provider starts talking about a planned C-section and you're like, well, this isn't exactly what I want. And they're not really like giving you other options or talking you through what the different outcomes could be. It is not too late to find a new OB or midwife.
Yep. Yeah. And breech birth is incredibly safe, with the caveat, the understanding that that provider needs to be trained in breech. It is not safe to have a breech baby with a provider who has no breech training, because the birth is actually very different. The way that we interpret your baby's well-being, the way that we interpret their signs, the way that your baby looks and what we're actually looking for, the signs that something like a shoulder dystocia is happening looks very different when you've got a cephalic baby, so a head down baby. Their head is out and their body is inside of you. But with a breech baby, you have to think their body is out and their head is inside of you. And so they just take different skills, but those trained providers are definitely out there. Breech Without Borders is a great resource. Our team is trained by them, and we attend breech births all the time. And it's just really special to see women be able to be empowered to not be forced into a cesarean when ultimately they don't need one.
Are there OBs that will attend breech births in the hospital?
Absolutely. That's we've had only one breech home birth in all my 10 years, and the rest of them are all in the hospital.
How can somebody find a provider that is willing to help with a breech birth? Because I feel like more often than not, women feel like the only option, if they're full term and they have a breech baby, their only option being presented to them is a C-section.
Yeah, well, Breech Without Borders is a great place to start. Dr. Stu Fishbein, Dr. Rick Safries, Dr. Nathan Riley, they all have really good intel and are very well connected to the breech community. Ask in your local Facebook groups. I will say this, there are a number of hospitals in the US that have breech bans, which if that took your breath away and you're like, oh my God, bans on our body. Yeah, there are hospitals out there who literally will not allow you to have a breech birth. And for me, I would say take your money elsewhere. Stop giving that hospital your money and stop being a patron of that hospital. Go somewhere else. And it does kind of sometimes come down to, should I drive 3 hours to a hospital that has a breech trained provider and I'm going to be able to have a vaginal birth rather than have a forced cesarean when that's absolutely not what I want? It is far and few between, but they absolutely do exist. You have many, many, many more midwives who are trained in breech birth. So also the other answer may be to leave the hospital system and birth at home with your breech baby in order to be able to access a trained breech provider.
Your providers should be honest with you. If you're asking them about their stance on breech or, what the breech options could be for you, this is another really good question to ask up front, because obviously not the majority of babies are presenting breech at the end, but it does happen. And so I think this is a good question to ask. We actually were just recently interviewing midwives in our new city. And I asked one of the home birth midwives, I said, are you comfortable with breech? And she said, yes. But she said, given your history of having babies that were 10 and a half and 9 pounds, we would have to see for you, because she said, I'm most comfortable with breech if it's like 8 pounds or less. So I was like, okay, that's fair enough. Like, I can understand that. That's a big baby to come out upside down. So but I really just appreciated her honesty about that, So those are really great questions to ask a potential provider at the beginning of your pregnancy. Ask them about their C-sections, ask them about their what their position is on breech. And are there other questions that you would recommend asking a provider to help minimize risk of an unwanted C-section, HeHe?
Yes, absolutely. What's your induction rate? What's your philosophy around waiting for spontaneous labor? How many unmedicated births do you attend each month? And they may give you kind of like a roundabout answer. Oh, well, I don't know. I would press them, y'all. I would press them. And you can get really kind of nitty gritty. Well, out of all of the births that you attend in 1 month, what's the percentage that you think, oh, I'm not sure, I don't keep up with that? Oh, just guess. Just give me a ballpark. Don't take a vague answer. And if they literally will not give you a solid answer, I personally take that as a huge red flag. It feels to me as if, well, I guess like, what other profession doesn't keep up with their stats? And like, if they just like quickly thought about the births that they attended in a 30-day period, they could round it up to like, I do 200 births a month. And I think about 100 of those go unmedicated and about 100 of them have epidurals. And then you can say, well, about in those 200, how many would you estimate end in a C-section, And again, you're not going to go back and fact check their numbers, but you're just looking to open a conversation. I also think that it's really important to ask them how comfortable they are with upright labor and upright pushing, because if you have a provider that has only delivered people on their back and they are only comfortable with that, but for you, it's an incredible priority that you don't birth on your back. When it comes time for you to push your baby, you are going to be in a tension struggle with that provider, because they're going to continue to say, I need you to get on your back. I really need you to get on your back. I cannot birth your baby this way. And you are going to be stuck in this position of, wait a minute. You should be able to birth my baby in any position. You went to school for so long. You should have these skills. Why do I have to accommodate you when this is my birth? Why do I need to accommodate you when you're the trained professional? I shouldn't have to change my birth plan to make you feel comfortable. And it's just much better if you know that going in as well, right? I also think another really important question is, how will you feel if we reach a crossroads in any decision along this way and I decide to politely decline your recommendation and I feel informed and confident in going a different direction? That is a very telling question too. You want a provider who says, you know what? I give you my recommendations because I genuinely care about you and I believe that my recommendations are best. But ultimately, the decision is yours and I trust you. I believe that you are smart, you're capable, you're able. And if you decide that something is best for you, I'm going to trust you. As long as you trust me to come to you when I see a problem, I want to leave an open communication line between us. That's perfect. You would never want a provider who fires you or turns their back on you or becomes hostile because you decided for some reason that you didn't want an IV. That's a really common thing. Medical professionals feel very, very, very validated and they really appreciate having an IV line, whereas most unmedicated births never need an IV. They just like to place one just in case.
Yeah.
That is a risk that you take to not have one. But if you feel informed and confident to do so, you want to make sure that your provider is not going to treat you differently or incompassionately going forward in your birth because you decided that you didn't want an IV line placed.
Yeah, exactly. Exactly. That's so spot on. Okay. So those are some great questions for you to consider asking your provider or a provider that you're interviewing up front. But now let's fast forward, 9 months. Somebody's full term and they're either going into labor naturally or they're deciding to have an induction. What are things that either do or don't happen during the labor process that will increase cesarean risk?
So those are different, right? If you have waited for spontaneous labor, that in and of itself reduces your risk for C-section a ton, like so much. If we are inducing electively and there's no medical reason for you or your baby to be induced, your risk for a C-section can increase up to 50%.
Yep.
And remember, I talked about the different protocols. And so you've got some hospitals who start you on Pitocin right away. But if your cervix is not supple, it's not effaced, we want a nice, squishy, thin, soft cervix before we put Pitocin on it. That requires usually something like Cervidil or Cytotec. These are prostaglandins that are inserted vaginally, and they're going to give you that supple cervix. So it usually takes a couple of doses as well. So for anyone looking into an induction, you actually may have, people are very surprised by this, 12 to 36 hours of not a lot of movement or what you perceive as like not really doing anything, but your body, your cervix is getting soft, right? Ready for your baby to drop and then give that downward pressure. You also may consider something like a balloon, although that is artificial or like mechanical downward pressure. And when we take that balloon out, sometimes we see that progress kind of goes away.
And also, it's like extremely painful.
It is very painful. And that's a place where a lot of people get an early administration of an epidural, which then also increases your risk for a C-section, right? If you're unmedicated, then that in and of itself decreases your risk for a C-section. The other thing that we want to consider is movement and being upright. So if you have an epidural, think about doing what I call the rotisserie chicken. You want to be on your left side, and then you want to be in hands and knees. And we want to think about, I'll get my pelvis down actually. We want to think about your pelvis being so upright, you maybe are sitting or you are in the throne position. And then maybe you get on your left side and you put a peanut ball between your knees. And so you've got kind of this movement. And then you get on hands and knees. So now your pelvis is upright. Then you get on your right side and you do that peanut ball. So you've got all this movement inside of your pelvis. And then you start it all over. So we're back to upright, left, right, back to the front, right? And so we really want to think about that rotisserie chicken period being very mobile for your pelvis. The point is that your baby is dropping and spinning in a corkscrew movement. We want to facilitate that with the way that we position your pelvis. Now, if you're upright, if you are unmedicated, then you probably will do this naturally because it's very hard to sit still if you are unmedicated. You're going to naturally be in a squatted position. You're going to naturally put your foot up on a birth bar. You're going to naturally want to get out of bed. You're going to naturally want to get into kind of a Captain Morgan or hands and knees. But in terms of reducing your C-section, waiting for spontaneous labor, being unmedicated as long as possible, and upright labor are probably your three most important things. If you are induced, making sure that your cervix is ready before we increase or we add Pitocin. And then there's this caveat too about not pitting to distress. And this is a common phrase that we hear in the hospital. And it means that we give you so much Pitocin that it causes fetal distress, right? And so this idea of pitting to distress is a pandemic essentially across our nation's hospital labor units. And so what we want to do is really shift that paradigm. And there's a lot of people who are doing this work. Jen Atkinson and Heidi Nielsen are doing the work within the hospital system. I have a free download for Pitocin Guide that teaches you as the mom, the parents, the consumers of how do you advocate for this shift in paradigm? How do you advocate for appropriate Pitocin use? And then you can refer to the FDA regulations, which I know the FDA is tricky, but they do have some good things. And their Pitocin regulations are actually really beneficial. But what we find is when we look at the FDA regulations and we look at hospital policies, there's a big discrepancy. And you've got hospitals that are using 15, 18, 20. The highest I've ever seen it is 28. Do you know that the FDA says there's rarely a use for over 10 milliunits of Pitocin, and you have more than doubled that? You've almost tripled that. And then we wonder why people are in so much pain, having birth trauma, needing an epidural when that was not their plan and they really, really didn't want it. And then we're leading to C-sections. That baby was never meant to take on 28 units of Pitocin. The body, the endogenous oxytocin would never, ever, ever be dispersed like that from your brain. Yeah. This is artificial Pitocin and we're using it inappropriately, and we must look at the results in which it is producing for us. And they're bad. They're not good for us, for our babies, for our stats. The only thing that it's good for is really the hospital's ROI, their bottom line.
If you're pregnant, postpartum, or running on newborn sleep, this one's for you. Your body goes through a lot during this season, and I've learned the hard way that gentle support matters. That's why I've been using the Loombox, an at-home red and near-infrared light therapy device that supports energy, recovery, mood, and muscle soreness. It's FDA registered, non-invasive, low EMF, and takes just a few minutes a day. No supplements to remember, no extra decisions, just light doing its thing while you rest. Check the show notes for the Loombox link and use my code OrganiMama for 40% off, because taking care of yourself is taking care of your baby.
Some of the listeners will know my birth stories already, but just like you're saying, like my first birth was an induction with Pitocin. I chose to not have an epidural, so toughed it out. It was so intense that I honestly gaslit myself into not even thinking I was in labor with my second baby, because it was just so much like less bad. Like there was just a night and day difference between the intensity and the pain of the first time versus the second time. Like, I'm not going to say it wasn't intense, especially near the end. It was, but just nowhere even near what it was like on Pitocin at level 10. And also the other thing that he hasn't mentioned yet is that when you're on Pitocin, you're not necessarily getting into that rhythm that your body would actually naturally put you in physiological labor. So For me, with Pitocin, I got no breaks in between. So every contraction was back to back to back to back with like maybe a 5 to 10 second break if I was lucky, versus with my home birth, I was literally getting a 2 to 3 minute break between every contraction, even up until I pushed him out, which that's longer than I think average. I think a more average woman is going to have like maybe only a 30-second break between contractions at the end. But for me, my body was literally like, nah, we're good. Like these contractions are working. So we're just going to take nice, long, big breaks in between. And oh my word, the difference that it made in the ability of me being able to trust my body to do its thing was massive. And like, I'm grateful that I didn't have more interventions in my first birth. I got lucky, honestly. But yeah.
Can I talk a little bit about the pharmacology and how our body responds to Pitocin? So when you have endogenous oxytocin, so this is natural organic oxytocin that is put out by your brain. It's a cocktail of hormones, actually, and oxytocin is just one of them. We've got two things going on. First, it is a wave, essentially. So you'll see that oxytocin peaks and then it drops, and then it peaks and then it drops. Well, when you've got Pitocin coming through an IV, it's actually more of a steep incline. It's a steady upheaval, and there is no break in it. So if we were truly trying to mimic what endogenous oxytocin would do, we would raise it and then we would lower it, and then we would raise it and then we would lower it. We're not doing that in the hospital. We literally just increase it and increase it and increase it and increase it and increase it. With endogenous oxytocin, when you get a big spurt of oxytocin, your body also puts out pain relief. And so I talked about this hormonal cocktail. They work together. Your body puts out oxytocin and then it puts out pain relief. And then it puts out oxytocin and then it puts out pain relief. We don't have that with artificial Pitocin. Not only is it artificial, so the reuptake inhibitors in your brain it's metabolized a little bit different. It interacts with your metabolism and your brain a little different. And so your brain knows like, this is kind of like oxytocin, but it's not oxytocin. So do we need the pain relief? I'm so confused about this. And that's why we see the pain be amped up so much, and it is perceived. So if you had that same level of oxytocin, it actually wouldn't be more painful because your body would be able to match it with the pain relief hormones, right? But because it's synthetic, your body gets a little confused, and so it doesn't match it. And so therefore, you are experiencing more pain. But typically, too, we're seeing Pitocin be administered in levels that are unnatural. So your body would not actually be putting out that much endogenous oxytocin. And so we just have to think about what that synthetic version is doing inside of our body, and we want to just be very mindful of it. In terms of protocol, we also want to be very mindful of how long it takes artificial Pitocin to get through our body for us to actually see the peak. So a lot of times hospitals are working off of what's called Q15. This means every 15 minutes, they are coming in to increase your Pitocin. And for many hospitals, they are doubling that dose every 15 minutes. So let's say that you start at 1 p.m. with 2 milliunits. And then at 1:15, they bump you up to 4 milliunits. And then at 1:30, you're bumped up to 8 milliunits. And then at 1:45, you're bumped up to 16 milliunits. Okay, now within 45 minutes, we've already surpassed what the FDA says, right? And then at 2 p.m., you're supposed to go up to 32. Most people don't get there because 16 is a lot, right? A lot of people might even find that 8 is too much. And I think a lot of people too don't realize that they can turn down the oxytocin or the Pitocin. And so you find that people say, like, these are too strong, these are really painful. And instead of their nurse or their provider saying, would you like to turn it down? We can titrate it. We can turn it up. We can turn it down. We can play around with it to find your particular good sweet spot where you're having rhythmic contractions, but they're not too much for your body. They don't do that. They say, well, if you're in too much pain, we should get an epidural, you know? And at that point, you're like, well, darn, I really wasn't wanting an epidural, and I'm X centimeters, which definitely I don't want it that early. I, I don't know my other options. And so, just if you're listening out there and you think that you may have Pitocin, or you don't think you're going to have Pitocin, I want to put this bug in your ear. You can turn your Pitocin down and you can turn it off. My number one trick for getting fetal distress to resolve for someone who has Pitocin is turn that Pitocin off. Almost always, we will see babies come back to a normal state, a normal healthy being, and then you can consider if you want to add Pitocin again. And at that point, think about, how much are we going to add? How fast are we going to turn it up? Are we going to reach the level of Pitocin that I was just at that my baby showed they had a hard time tolerating? So you've got a lot of control here, even if your hospital isn't necessarily presenting it that way.
Okay, so I have a question. So let's say somebody decides to do an elective induction and they start with Cytotec or Cervidil, but they move on to Pitocin. It's really intense. They don't want an epidural. Maybe they're starting to notice a little bit of fetal heart tone distress. Is it possible for someone to say, actually, I don't really want to keep going through with this right now. Can I go home? Can that happen?
Totally. Absolutely. We've had so many clients over the years do it. You've got one big caveat. Your waters still need to be intact, which means it is so utterly important that you avoid amniotomy at all costs. So this may look like having a really, really strong boundaried conversation with your provider. Yes, I'm okay with cervical checks. And yes, I'm okay with you placing Cervidil or Cytotec, but I am absolutely not consenting to you breaking my waters. Please don't do it on accident and do not do it on purpose. It may look like you saying, you know what, I'm all set. I actually don't want any sort of cervical exams. I don't want anyone up there because I don't even want to take the risk. And sweeps are another thing. So there are so many times where you go in, you consent to a sweep, and then your waters are actually accidentally or intentionally broken during that procedure. So I always recommend having a conversation about what you do and don't consent to. It's not impossible that they are accidentally broken, but it is a little difficult to accidentally break your waters. They have to be very, very, very thin. And the amniotic sac is just not. It's a pretty thick sac to start with. And so, it usually takes some intentional work to break that amniotic sac. But yeah, as long as your waters are intact and your baby is looking good, you can absolutely go home. Now, some of the medication is going to have to be worn off. And so you may find that after you stop the Pitocin and after you, kind of decide you want to go home, that they do keep you for a few hours to monitor you and your baby. So you'll still have the belly bands on. But once you and your baby are looking good and you've got this stable pattern of well-being, you can absolutely go home. And you want to know something, just anecdotally, this is not evidence-based. It's just what I've kind of observed over the last 10 years. Most of those people will go into labor naturally before they come back for their next induction.
Yeah, that doesn't surprise me at all. Okay, two things I wanted to mention based off of what you just said. The first one is just regarding inductions. I think the first time I heard this, it kind of blew my mind. But if your provider is suggesting an induction to you and they're saying it's for health concerns regarding you or the baby, if they are scheduling it out for a later date, it's not actually medically necessary. If they were genuinely concerned about you or your baby and they're like, hey, we think we should induce you next week for medical reasons, if they actually were concerned, they would tell you, you need to go up right now and get induced, or you need to go up right now and have an emergency C-section right now. If they are scheduling it out for a week or 10 days away, there is no medical reason for you to be induced, because that is total baloney.
It's for convenience.
Yeah, exactly. Maybe they want to go on vacation or something and they're just not telling you that. And they're like, oh, well, we think that your baby's a little too big. So, okay. The second thing is that I actually don't know if this is evidence-based, and maybe you would know this, HeHe, but I have heard anecdotally from multiple very experienced midwives that women who are really, really on top of excellent nutrition in pregnancy are much more likely to have an amniotic sac that doesn't break until the end, because a more nutrient-dense diet during pregnancy, anecdotally, I guess, you can tell me if this is evidence-based, a more nutrient-dense diet will actually help your sac be thicker. And so it's less likely to be accidentally broken by your provider. And it's also less likely to just break at the beginning of labor. You're more likely to just begin labor naturally with contractions and then have your water break later on in the labor process, unless there is like maybe a uterine infection happening or starting to brew that might make your water break earlier.
Yeah, or if you had any sort of infection during pregnancy. So let's say you got some sort of viral or bacterial infection, or you had a UTI or BV during pregnancy, any sort of infection. And when I say viral or bacterial, I'm meaning like head cold, some sort of pulmonary infection. So like pneumonia, anything like that would increase your risk of it increases your risk of preterm labor, which typically starts with your waters breaking. The data suggests that the nutrition plays a role, but there's really interesting data. And this is something I'm doing in my pregnancy. I have an orange a day. And if I don't have access to an orange or a tangerine or something, I will have a kiwi, something with high vitamin C, because there's very good data that says the high vitamin C intake in pregnancy can actually reduce the risk of weak amniotic sacs, which is going to reduce your risk of preterm labor. Now, what we don't know is the exact definition of high vitamin C, and that's where more research is needed. This is kind of older research. We kind of did the research and then we found like, oh, vitamin C is really healthy, and we haven't done anything with it since. But if you are concerned about preterm labor, if you have a history of preterm labor, if you are concerned about having a weak amniotic sac, try and just have some vitamin C every day in your pregnancy. What's it going to hurt? It's not going to hurt anything, even if it doesn't help something.
Yeah. And I would say this just kind of concept of like nutrient dense, high vitamin, high mineral diet in pregnancy was true for me. With both of my babies, my water did not break until the very, very end. And actually with my first, when I had my induction, they broke my water when I was like at 8 centimeters, because I was struggling with having no epidural during all this Pitocin. And my midwife actually suggested switching to a new position, being on my side with a peanut ball and breaking my waters. And sure enough, that actually kind of made everything happen much more quickly. But I waited as long as possible before I agreed to that. But with my son who was born at home, my waters broke as he was crowning. And it was literally like my water broke. And then I immediately had the fetal ejection reflex like 2 seconds after that. And he came out into contractions, which was wild. So I'm just grateful that I haven't had the experience of having my water break before. Because I honestly think that has made labor a little bit, or at least with my second, it made labor easier. Because I've heard that when you don't have that cushion anymore of the amniotic fluid, it can make things a lot more intense.
Totally. I would say anecdotally, that's what I've seen as well.
Yeah. Okay. So we've talked a good amount about inductions and C-section here. Now I want to pivot toward those who have had C-sections in the past, whether that was a planned C-section, but more likely than not, it was not a planned C-section. This is the majority of women who are in my DMs asking about VBACs and C-sections are ones who said, I didn't want a C-section, but I ended up with one. And now I'm pregnant again and I really want a different experience. What would your very, very best advice be to someone who is newly pregnant, has had a C-section before, and would really like to go the vaginal birth route for a recurrent birth?
Find a VBAC supportive provider. And this does not mean VBAC tolerant or VBAC friendly. It means they genuinely support VBACs openly. They are like truly supportive of them. They're not going to force you into a mandatory induction. So for me, that's always kind of like a red flag when they say like, yeah, I'll support your VBAC, but just remember that you aren't allowed to go past 41 weeks. And it's like, well, of course, induction should be available to anyone who wants it and is trying to VBAC, but it shouldn't be mandatory. It should never be mandatory without a medical necessity. And so we also know, I guess, that not only does VBAC have a slight increase, it's still less than 1% of uterine rupture, but increasing that risk is going to come along with introducing Pitocin. So if we already have an increased risk, albeit be small, less than 1%, if we're trying to keep that as small as possible, why would we force someone into an induction without a medical reason, right? The other thing is that they force you to have an epidural. That's something I've heard over the years. Yes, I'll support your VBAC, but unmedicated VBAC is not allowed. We force you to have epidural. That is just so silly to me. You want someone who is, yes, VBAC is totally possible for you. Yes, I'm going to let you wait for spontaneous labor. No, I would never force you into an induction. No, I'm not going to give you an arbitrary cutoff in gestation in which you can and can't have a VBAC. I'm not going to restrict you in your pain relief measures that you can and can't have, or tell you that you must have certain things. Any provider who genuinely believes that they have the authority to make those type of decisions for you is a big red flag, because their whole job is to support your autonomy and to allow you medical freedom to make the decisions for you and your baby and your body, free of their coercion or manipulation or influence. They should give you their recommendations and they should tell you their clinical opinion. But at the end of the day, the decision falls on you, because you're the only one that has to live with those outcomes, whether they be good or bad. You need to make the decisions because this is your choice.
Yes. And your doctor works for you and you are the frickin' boss.
Do you know that your success in having a VBAC, achieving a vaginal birth after C-section, comes down more to your provider's belief in that you can do it rather than any other factor? A big baby, spontaneous labor, at what gestation you have your baby, any of it. It really comes down to, does your provider truly believe that you can do this? Because if they do, they're going to do everything in their power to help you achieve your VBAC. And if they don't, they're going to do everything in their power to get you back to the OR.
Yep. Okay, really quick. You just mentioned big baby.
Yeah.
I've had big babies, but I want to hear your unfiltered opinion. Do you think there are women whose baby is too big to be birthed out of their pelvis and they need a C-section?
Not if your baby is in optimal fetal position. Now, can you have a big baby that is malpresenting and they are asynclitic, and no matter how much we push, or no matter how much we reposition, or no matter how much you are unmedicated, that baby's not coming out? Yes, I do. I believe that. I've seen it. A couple of years ago, I had a face presentation, which, your baby crowns, which means the top of their head, the crown of their head should present first. This baby was presenting with her face like this, and we pushed and we pushed and we pushed. And this was a second time mom. She already had a baby. So her vagina was kind of used to it. It was already primed and ready to birth a baby. And her first baby, she pushed for less than 30 minutes. This baby was not coming out. And it wasn't a humongous baby, but I do believe that humongous babies can come out if they are in the right fetal position. We want them ideally head down with their crown of their head presenting. I also do believe that breech babies can be super big and can be born safely as well. I've also seen that.
If your doctor is telling you, oh, based on your ultrasound at 38 weeks, it looks like your baby is pretty large, like 8 pounds already, and they're probably going to be 9 pounds by this time next week, and you're really petite, you've got small pelvis, we just don't think it's really possible for you to give vaginal birth, so we should go ahead and schedule a C-section. Is that legit?
No, I would ask them, do you have a vacation you're trying to get to or what? So what you're talking about is called pelvimetry. It is the attempt to estimate the size of one's pelvis in comparison to the size of your baby. Not only is it not evidence-based, it's quite outdated and it is so inaccurate. The other inaccurate thing that we're using in this scenario is ultrasound. So not only is ultrasound really not reliable for the estimation of baby's weight, which that's per ACOG, okay? That's not me making this up. That's not some sort of like crunchy idea. ACOG literally says that estimating fetal weight via ultrasound in third trimester is not reliable. And so you want to remember that actually the later you are in pregnancy and the bigger your baby, the more inaccurate it is. So it's not just inaccurate because it's inaccurate. Now you've got a compounded factor that you're really late in pregnancy. You're at 38 weeks. You've got this seemingly big baby, but how many times have you seen a baby be estimated to be 10, 11 pounds and they're born at 7-9 and you're like, this wasn't even an 8-pound baby. What if I had a C-section for that?
Yeah.
That's crazy, right?
And even like big babies can also get missed. Like in my case with my first, I had ultrasounds at 41 and 42 weeks. They had no clue that she was 10 and a half pounds. Like there was not even an inkling of, hey, she looks kind of big. Like there was no comment on that whatsoever. So that got completely missed. And then everyone was shocked when she came out and was huge. So now, obviously, this is a conversation for another day, but I had gestational diabetes that got missed by the screening. So that's how that happened. But we took care of that the second time around, and 9 pounds was much better for me than 10 and a half. But anyway, if your doctor is telling you that you need a C-section based on an estimation of their size from an ultrasound, you probably want to consider respectfully finding a new provider.
Totally. Yeah, absolutely.
Okay, HeHe. So what, if anything, what else would you add to moms who are wanting to prepare for a C-section or avoid a C-section, or mothers who are hoping to achieve a VBAC?
Yeah, those are two different things. So let me start with the VBAC. For VBAC, you really want to take care of your scar. So your scar heals in a tourniquet fashion. You're going to have a lot of tension and tightness around that scar. So think about getting in with a PFPT who can step you through scar massage and helping loosen up any of that scar massage down there, plus help evaluate any sort of like inequalities in your pelvis. Sometimes we see that one hip is higher than the other, or you've got tension on the left side and some looseness actually on the right side. Going into any birth, one that's a VBAC or one that's not, we're looking for a neutral pelvis. In addition to that, chiropractic care can be super helpful, especially if you're working with a PFPT who has identified some inequalities in your pelvis, right? And then I love other modalities like, oh my gosh, red light therapy, dry brushing, lymphatic drainage, acupuncture, anything that you can do to bring awareness down to that scar, break up that scar tissue, and help encourage your baby to get in the right position and help your pelvis to get neutral is going to be super great. I also think that preparing mentally for a VBAC is very different than someone who's not. You are going to face a lot more pushback. There's a lot of fear around VBACs in our hospital system currently. It is unfounded. VBACs are so safe. We know that they're so safe. ACOG supports VBACs. all midwifery organizations support VBACs. If you look at VBACs around the world, they're really supported. That doesn't mean that that's going to translate into the care that you get in the hospital. So just prepare yourself that you may have some pushback depending on who is on call when you go into labor. When you're preparing for a C-section, I think that finding the joy is really good, right? So instead of filling yourself with fear, fill it with like the joyous parts. You get to schedule it. That's so convenient and easy. You can go in and choose your provider. That's amazing. You don't have to work off in an on-call schedule. You can look at who's on call and choose the provider that you feel great with. You have so much control. Ask for your arms not to be locked down. Ask for that clear drape. Have discussions about skin to skin in the OR or a maternal assisted C-section. Ask for things like vaginal seating too. So you can put gauze into your vagina the night before your C-section, or if you wanted to, you could do it for a couple of nights and you put it in a little baggie and you freeze it in the bag and then take it in. And they'll actually wipe your baby's mouth, inside of their nose, their eyes, their ears, their hands, so that when they suck on them, you can wipe it on your nipple. And that way, as your baby passes through your vagina, they get inoculated by your gut flora. With babies that have, that are born via C-section, they miss out on some of that. Once your water is broken, we get a little bit of that inoculation. But in a C-section, it's like your waters are broken because we cut through that amniotic sac, and within seconds, your baby is out of your belly. And so that inoculation is just much smaller. It's a much briefer amount of time. And so you can still achieve similar results by vaginal seeding. And so have these conversations. I really think that preparing for a C-section is having intentional conversations so that you know exactly what to expect, you know exactly what your boundaries are, and you set up your care team to match your expectations. So they have expectations of you, and you should have expectations of them, and you should all have expectations of how the surgery is going to go. And then I think preparing for that healing period is going to be super, super important as well. So think about having a lot less mobility. So you're probably going to want someone to help you get up and down from the couch, in the bed, in the toilet. You won't be able to shower for a little bit. Feeding your baby might require a little bit more accommodations than someone who had a vaginal birth, because you do have that incision site. And so having a breastfeeding pillow or a baby lying across your belly may be a little bit more uncomfortable. So instead of doing like side lying, you might find that football hold is a little better, or you could side lie actually on your side and have your baby lay on the couch or the bed and nurse from your bottom breast. And then you flip over and you bring your baby with you, and they nurse on the other side when that breast is on the bottom, right? And so you just got some accommodations. Healing from a C-section, a lot of people discount that your vagina is going to need healing as well, and it still will. So you will still bleed vaginally post C-section, where a lot of people think, well, I didn't have a vaginal birth, so I must not have vaginal bleeding. And that's not true. A lot of people bleed for less amount of time, but you're still going to have vaginal bleeding. So you're actually going to need to have some vaginal healing tools around your home and some C-section tools around your home. I love scar patches for your C-section once your stitches or staples or glue have dissolved or been removed.
Yeah. Such good advice, HeHe. I feel like we've only really barely scratched the surface on some of these topics, and I feel like we could just keep going for hours. But if listeners want to learn more from you, can you tell us a little bit about the Birth Lounge?
Yeah, absolutely. So the Birth Lounge is an online comprehensive birth course. And so I say comprehensive because I feel like a lot of childbirth educations teach you what your options are, but what they fail to teach you is how do you actually achieve those in a hospital system that is not designed for you to be able to take advantage of those options. And that's what I do differently. So it's unbiased, it's non-judgmental, it's data-driven. Every single thing I say in the Birth Lounge can be backed up with data that is linked under each each video. And not only do I teach you what your options are, but I teach you scripts and how you can have those conversations with your provider. What do you do to actually advocate? And if you face pushback from your hospital staff, how are you navigating those situations too? And then you can find me online on any platform at Tranquility by HeHe or the.birth.lounge on Instagram.
Amazing. Well, HeHe, thank you so much for spilling all of your knowledge on birth and C-sections and VBACs and inductions. It's just so great to hear from you and just see such a positive, cheerful advocate for birth be talking about these things in an evidence-based way. It's so great. And I'm sure lots of women listening to this will have learned a lot. So thank you so much. Guys, we will tag her accounts and the Birth Lounge in the show notes. So feel free to go check those out. And we'll catch you next time on the next episode of the OrganiMama Podcast.
If you just got that positive pregnancy test for the first time, welcome to pregnancy, where your cravings make no sense, your apps all disagree, and suddenly everyone on the internet is yelling at you. Should you be eating protein? And what actually happens at ultrasounds? Why does nobody explain the glucose test until it's happened already? That's why I created the OrganiMama's Guide to Pregnancy. It's like having a calm, informed, holistic best friend walk you through pregnancy and birth, trimester by trimester, without the fear-mongering or overwhelm. If you want less Googling at 2 a.m. and more like, oh, okay, I've got this, check the show notes, click the link, and grab the pregnancy guide. Podcast listeners can get 20% off with code PODCAST.